Now I have the pleasure of inviting Associate Professor David Smith, who is one epidemiologist that puts the language into the lay category so that we can all readily understand it. And Pam and I and others have worked with David for many years, and we're really appreciative of him coming tonight. And he's going to talk about the current status and future trends. As you know, David works at the Cancer Council of New South Wales, so we're very much looking forward to another excellent presentation, David. The floor is yours.
Thank you very much, David. Evening all. Thank you very much, David and Pam, for inviting me. I was actually due to come a couple of months ago, but some family health issues kept me at Royal Prince Alfred that night rather than coming here. So I know I would much rather have been here than where I was, but now is my moment. And so I'm going to talk to you about some current status and future trends in the world that I occupy. And the majority of the world that I occupy is focused on prostate cancer. So I think you'll find it relevant from that point of view. As David said, I work for the Cancer Council of New South Wales, and I've been there for about 18 years now. In a couple of different roles. I worked for Breast Screen for a while. I've worked with the Cancer Registry for some years as well. But the last 10, 12 years has been working in the Epidemiology Research Centre with pretty much a focus on prostate cancer. Now, epidemiology is sort of, it's the front end of this particular diagram of where in the Cancer Council we work upon. It's the research side of things. But we're not the guys that look down microscopes. We, as epidemiologists, take the big picture, so like the helicopter view of research. And our role is to try and compile, in the best possible fashion, evidence. And as you'll be aware, evidence is extremely important for shaping where we go and public health issues and understanding more about the different diseases that we work on. So that's really who I am. The rest of the other parts of the Cancer Council work on advocacy, prevention, support. There are about 400 full and part-time staff in King's Cross, Woolloomooloo, in the office down there near just off William Street. It's an extraordinarily interesting place to work, as well as working for the Cancer Council as well. So today I'm really going to talk to you about sort of 4 things that are going on in prostate cancer, the epidemiology of prostate cancer in Australia. And my take-home message here is that we currently have the unenviable position of being at the top of the international rankings of incidence of prostate cancer. And we'll talk a little bit about why that is and where that's going. There's also some work that one of my colleagues is doing projecting the prevalence of prostate cancer, and we estimate that by about 2017 there'll be 267,000 prostate cancer survivors. Hence, as David mentioned, a real need to provide the support that's needed for that group of men moving forward. I'm going to talk about the prostate cancer care and outcomes study, and we've got some data that's a sort of 10-year survivorship cohort, and this is really where the quality of life issues that you might find interesting is sit as well. And at the very end, I'm going to see whether any of you might be interested in being involved with some research and talk to you a little bit about a study called Living Well with Prostate Cancer. It's a new study, and we're recruiting. And we're recruiting from this hospital or this centre, as well as a few others around New South Wales and a couple of the other states as well. So I'll talk about that, and if anyone's keen and is eligible, then come and have a talk to me. Okay, today was a bit of a different day for me. I spent most of my day presenting to the media the results of a study that we've just done in New South Wales, and it was a study using the 45 and up study, which some of you might have been involved with, and we analysed some data and got it out there, and it's really talking about healthy lifestyle. This particular one from the Australian Healthy Lifestyle Protects Sex Life study. We asked 108,000 men in New South Wales aged over 45 about their erectile function and erectile dysfunction, and we presented it in this report, came out in the Medical Journal of Australia today. And the 3 kind of issues that we were really talking about today is that unfortunately erectile dysfunction is a very common ailment or issue that face older men. Men. Look, it's over 45-year-olds now, so that I'm in that group, and so I can talk with authority. As men age, erectile dysfunction becomes more of an issue, unfortunately, and so we've looked at each different age group. Whether men had prostate cancer or didn't have prostate cancer, and this particular paper subsetted men with prostate cancer, and in fact men with prostate cancer have the highest rates of erectile dysfunction, not surprisingly I guess. But the other three sort of questions and poses that we're putting out there, we're saying that there are modifiable risk factors for men who don't have prostate cancer, and they're generally the healthy lifestyle issues. So if men smoke, they're about 86% more likely to have erectile dysfunction. If they're overweight or obese, they're about twice as likely to have erectile dysfunction. And if they have a sedentary lifestyle, they don't get much physical activity, they have higher rates of erectile dysfunction as well. So that was our story. Get off the couch, quit smoking, and lose some weight, and you may prolong your sex life. So there was a bunch of, we did have 45 hits from the 702 I've been speaking to, and the age, erectile, woe, high in the city. We found a very small difference that men. This is one area where men in the rural areas do slightly better than the metropolitan areas. The percent of men who have erectile dysfunction is higher in rural areas than metropolitan areas, and a lot of people were interested in talking about that. We didn't really have an explanation, but. This fits nicely with Cancer Council key messages that overweight and obesity can increase your risk for a number of other things as well. So it's been an interesting day, not particularly about prostate cancer, but about issues that affect men's health and welfare. Okay, so the first thing I mentioned before, and here's some evidence behind it, is that Australia and New Zealand currently occupy the top of the international rankings in prostate cancer incidence. The top map is the incidence rates, red being the highest, and the dark blues being the lowest incidence rates. Now these are all adjusted for age, and so they take into account that there are different age populations and structures internationally. And we and the North Americans and the New Zealanders and some of the Northern Europeans have the highest incidence rates of prostate cancer internationally. Mortality is a slightly different picture, but for a country that's developed and has good health services, we still sit in that relatively high band of the dark brown in terms of the mortality from prostate cancer as well. And I'll get onto that a little bit more, but this picture really indicates where we lie in terms of prostate cancer internationally. So much of what we know about prostate cancer reveals very little about risk factors, as you're probably aware. And we think that this particular map at the top reflects screening, PSA testing, and detecting prostate cancer, as opposed to some of the countries that probably don't have health systems set up that will detect prostate cancer. There may, however, be racial differences between countries, and there are racial differences between different ethnic groups, but most of the issues here probably relate to screening in the highly developed European, American and Australian and New Zealand populations.
Could I ask how accurate your data would be on the reason for death in some of these other companies, particularly looking at that whole Northern European part there? Do you think that prostate cancer isn't identified, or do they just all die of pneumonia, which of course is a very common cause of death, when there's no other specific mentioned?
That's a very good question. These statistics are put together by the International Agency for Research on Cancer, and there's an understanding that quite a lot of that has to be estimated based on a couple of hospitals that might be notifying from certain areas of Africa. So there's quite a lot of estimation, and it may be that some men just never reach the age when they can be diagnosed with, or prostate cancer appears on the death certificate. There's also a lot of difference across developed countries about how well deaths are recorded on death certificates as well, and that makes this stuff very murky, so quite complicated.
It was a good question.
Is there any explanation for the high degrees of mortality rate between Australia and, let's say, compared to the United States and Canada? Why there is a difference, given that you'd expect there'd be an expectation of similar sort of levels of mortality and treatment?
That's an extraordinary, pertinent, good question, and I come back to that later, where I present a little bit of data, trend data, about the mortality rates that have been occurring in Australia, USA, Britain, and Canada, and we aren't doing as well as US or Canada, and we're not really sure why. It's probably something to do with treatment and the way the services are provided, but the reasons behind it are not entirely clear. And we're doing some collaborations with some from Royal North Shore who also got interested in this and trying to get behind it a little bit more. And really, one of the things is to present it and say, look, we're not doing as well as we should be. What's going on? Let's get in behind this a little bit more and find out exactly what's occurring. So I don't have a quick answer. It's something that we're very much looking into. Well, this really ties into it, and as I said, I'm presenting some data here, and these are the incident rates and trends over time from when we first started recording the incidence of prostate cancer. In Australia is the red line, and almost all countries, or the three of US, Canada, and Australia, had experienced what we call the PSA spike. Some people call it the Mexican's hat, sombrero, the way in which prostate cancer was travelling up a little bit before PSA, before the prostate-specific antigen test arrived, then shot up in the States, in Canada, and in the USA. Notice how, though, in the UK, where the health system is very much different and has been, I guess, discouraging prostate cancer testing, that their incident rates have been snaking up and have started to creep up a little bit more, but they didn't experience the Mexican's hat. It's only relatively recently that we've overtaken the US as the country with the highest incident rates of prostate cancer, and it looks as if we're now seeing a downtrend. So the second spike appears to have abated, and prostate incidence appears to be going down. This is the chart that I was talking about that really explains, well, not explains, but shows the issue with mortality. So this is age standardised mortality over time for the four countries that I mentioned before, and all of them were very similar in the 70s and the 80s, but generally had an increase around about the time that the PSA spike occurred, and it's not entirely clear why the mortality rates started to spike up again around about that time. There was some thought that some death certificates there might have been more recognition that prostate cancer was a diagnosis, and it was written on a death certificate more commonly. There was, but nobody's really explained that peak particularly well. However, in every country, irrespective of the prevalence of PSA testing, there have been declines. The Canadians and the Americans certainly led the way here. And we're sort of trickling along with the POMs, with the British decline, at a rate significantly different from the US and Canada. So this is really another picture like the atlas, and we're scratching our heads saying, is it to do with testing? Probably not, because we've been quite aggressive in testing for prostate cancer. Is it to do with treatment? Well, it may well be, but what part of treatment? Is it treatment of men with locally recurrent disease or castrate-resistant disease? Is it something to do with the hormone therapy that's delivered and how it's delivered? Is it something larger with the health system and how it's set up? We really don't know, but we'd like to dig deeper and try and find out exactly what's going on. Prostate cancer horizon has changed greatly in the last 20 years when we've been recording data. 2009 is about the most recent period for when for the data that we have, and you can see the age structure is vastly different. There are about 20,000 cases of prostate cancer diagnosed in Australia in 2009, compared with about 4,500 cases diagnosed in in 1988, roughly 20 years ago, before PSA testing occurred. The average age of diagnosis has dropped. It used to be around about 72, and now it's about 60, 68. And so a lot more younger men diagnosed with prostate cancer in the current climate than in 1988.
So with the men that were diagnosed that are showing up there in the blue, would they all have had advanced cancer? I mean, how was a localized prostate cancer diagnosed then?
Yeah, no, they weren't all diagnosed with advanced cancer, but a higher proportion were. I haven't presented a statistic that breaks it down by stage of disease. More men were diagnosed with advanced cancer in the 80s, before PSA occurred, but not a huge amount more, 5 or 10% different than they are now. So most men would present with symptoms. They'd be diagnosed as a result either of a TERP or a digital rectal examination before PSA.
And those men that were diagnosed with localized disease, would they have sort of had some problems, say they needed a TERP, or did they have to have a biopsy, or were they given a biopsy?
Biopsy would have occurred there. In '88, radical prostatectomies were fairly rare, and so most men were either having radiation or androgen deprivation therapy, and the rate of radical prostatectomies certainly around '88 was very low. You could almost count them on, not quite on the hands of two hands, but very low rates of radical prostatectomy. Okay, I might just quickly go through this one because as well as trends internationally, there have been trends by state, and these are just the 4 states' data that I could get hold of. And New South Wales is the red one. In Western Australia, they experienced a much higher incidence in the early period, and that was predominantly from what we hear anecdotally, because there was one urologist in Western Australia who was promoted PSA testing early and regularly. And that's probably why Western Australia has the higher rates. Most states where cancer registration is up to date, and ours isn't particularly. If you notice, we've only got data to about 2002, 2007, 2008. There have been some major data privacy issues with the Australian Bureau of Statistics that we're trying to be sorted out, but it makes jobs for people like me very difficult when we're looking way back in the rearview mirror as opposed to looking at current data. Okay, the next couple of slides are really about subgroups of the population and their prostate cancer incidence and mortality. And the way to interpret these particular slides are, this is for where men live, remote residents, and it's for the whole of Australia. And the national average is represented by the blue line. Anything left of that line indicates a lower rate. So men from remote and very remote areas have a lower incidence rate of prostate cancer compared with inner-regional area men who've got higher rates of prostate cancer. The little lines either side represent the statistical confidence that we have around the particular estimate, and anything that crosses that blue line, we say, well, it's not really statistically different from the national trends as a whole. So major cities are very tight, and they're just slightly lower incident rates of prostate cancer. The mortality rate is the one that is of interest here, and the one that we get concerned by, because men from outer regional areas and inner regional areas, and these typically are Cessnock, so an inner regional area is somewhere just outside the metropolitan area, so somewhere like Cessnock and Leeton, for example, so an outer regional area, have got significantly higher mortality rates from prostate cancer. Now, does this reflect some screening issues that might have occurred or not occurred a number of years ago in those areas? Possibly. Or does it reflect treatment differences that the men from these areas are experiencing? Possibly as well. Again, it's very difficult to tease out what drives some of these issues, but it's likely that there's a combination of the two of those occurring.
Yeah, thank you. Just back on the incidents and the remote, very remote, that be relating as much as anything to this lack of access for the guys in those areas?
Yeah, it's likely that that's the case. Putting our finger precisely on why that would be, whether it's lack of access to radiotherapy or to certain aspects of high throughput teaching hospitals who do lots of radical prostatectomies. It's probably less the localised end of things than it is the men who've got locally recurrent disease, and potentially those who are at more risk of death from prostate cancer than general.
Thank you. And just the rough example of the remote and very remote, like out at Pilbara or something, or like North Queensland sort of.
Those ones would be very remote. You can see the populations that represents only 230 deaths. So it's a small but very different population that we're talking about. The fact that they've got low incidence rates probably means that they've got prostate cancer, or they're not being tested for prostate cancer as much as the metropolitan men. One of the other indices that the data allows us to look at is socioeconomic status, and this is derived from the Australian Bureau of Statistics collection on how many resources at an individual household level. And then we scale it up, look at areas and where men live. And you see that in terms of the incident rates, it's the men from highest socioeconomic status areas who've got the highest incident rates, compared with men who've got the lowest incident rates, also have the lowest prostate cancer incident rates. Now, this doesn't adjust for ethnicity, and we know there are some ethnicity issues in terms of the incidence of prostate cancer, so it probably represents a little bit on that scale, some of those things. Mortality rates, men from highest SES areas have got the lowest mortality rates, and it's men from the sort of lower end of the socioeconomic scale who've got the higher mortality rates. So there appear to be some equity issues in the incidence, but more worryingly in the mortality differences that we see across Australia. I mentioned very quickly, and this isn't a very nice slide, but this only represents data from New South Wales. It's the same sort of thing where the blue line represents the average. And this is the incidence and mortality by where you were born. And of course, about 75% of Australians are born in Australia, and they have higher incident rates than most other countries of birth. So Northern Europeans have got, or just on the line actually, but with Southern European men, Eastern European men, Middle East men, Asian and other, have significantly lower incident rates of prostate cancer than Australian born, or the average. New Zealanders are up there as well. And mortality rates, less of a gradient, but significantly lower mortality rates for Middle East, Asian and other areas. The mortality rates are probably being driven by the incidence rates, and we do know that there are some ethnic differences in terms of the risks. Whether these are genetic is one issue, or whether there are some diet, lifestyle and other issues that we don't fully understand about prostate cancer, but may be determining some of the risk that we see in terms of Australian born. It would be negligent to give a prostate cancer talk without talking a little bit about the trend in the number of PSA tests that occur, because we think a lot of what we've witnessed over the last 20 years in terms of the incidence of prostate cancer is driven by PSA testing. And these are really just the number of PSA tests that have occurred in Australia since 1994, which was a little after it was first put on the Medicare benefit schedule, to 2012. So we've got quite current data. And what we see is that about 1.6, 1.8 million PSA tests occur every year. The majority in the 55 to 64-year-old and 65 to 74-year-old age group. And what appears to have happened is that there's been a plateau in the number of PSA tests that have been occurring. Now, I know the PCFA do a really nice community attitude survey, and it would appear to back up the Medicare data that says that a lot of men are getting PSA tests. Quite a few men don't get tests, get tests, but they still aren't aware of it. But Medicare data backs up the fact that we might have seen a plateau in the total number of men that are getting a PSA test. You're probably aware that there's a lot of debate around the benefits and the harms associated with PSA testing, but these figures sort of play out that we may, like the incident rates, have seen some plateauing in terms of the number of men tested.
It appears that in the age group 55 to 64 that there's roughly just under 500,000 people tested.
Yep.
What is the total population in New South Wales in that age group?
Don't know off the top of my head. This is the total population of Australia.
Oh, I thought this was New
Sorry, no, this is Australia, but it's the same thing, yeah. We estimate, I think, that around about 50% of men in that age group are having a test or self-report that they've had a test, and in fact it increases each age group afterwards. That's using the PCFA Community Attitudes Survey, I think. So most men in this age group will have had a PSA test.
That's why it's plateauing.
Because we've used the prevalent pool. Having said that, if men are having tests every year or every 2 years, then we may see, yeah, we'll expect to see some sort of plateau in there as well.
Just wondered if those figures include statistics of people who are continuing to have PSA tests after they've been treated.
Yep, these are all. There are four different categories of PSA tests, and this is every PSA test. So some of this curve, there are different ways of breaking it out to show what proportion are the 66655 versus the 66656, which are the monitoring versus the screening. And roughly, in some age groups, it's about half-half. So, yeah. Okay, all right. The next little trend, epidemiologically, is North Sydney and the North Sydney area compared with New South Wales as a whole. North Sydney represented here from 72 to 2008 as the blue line versus the red line, which is New South Wales as a whole. And you see that before PSA testing, North Sydney and New South Wales, the rates were almost the same, very little difference. But PSA testing occurred and was probably taken up more by men from the socioeconomic demographic that was represented by North Sydney, and had significantly higher rates for most of that period, but it appeared to have come back to the bunch more recently as well, with a bigger drop. So it seems to be like it's the men from places like North and Sydney who are who may have been diagnosed at this earlier stage, and we're seeing a drop in the incidence rate as well. The next, I thought I had the next slide that went with that. Oh no, here's just the map representing very much the same thing about where North Sydney sits. So you'll see that there are 2 or 3 areas in the state of New South Wales that have high, and high is represented here by red. So Murrumbidgee, Hunter and New England, and North Sydney and South East Sydney have statistically significantly higher rates of prostate cancer than other parts of the state, and low rates in the far west and southwest and the Illawarra parts of the state as well. I'm trying to think the next slide. Some of this is okay. And if we jump into the local government areas and look at where particularly the high rates are, Hornsby's got about a 9.5% higher than average rate. Ku-ring-gai 16.9, Warringah 14.7. So we're actually in the middle of some fairly high rates of prostate cancer in Australia, in the world. So if North Sydney leads the world in something, it's in prostate cancer. And
Mossman certainly does.
well, not Mossman's really jumps out there, doesn't it? Yeah. Okay, so mortality, I'm sort of presenting one side incidence, one side mortality most of tonight, and the only areas that really stand out for prostate cancer mortality are the Hunter, New England and Mid-North Coast. And again, I seem to put most of these things up and go, here's some data, but we don't really know what's driving this. The chaps in Hunter are aware of this and are trying to get to the bottom of it and understand it a little bit more. The clinicians, I've spoken to them, and they can scratch their heads and raise their eyebrows a bit, but whether it's represented by the fact that generally the men from Hunter and New England had very low incidence rates for a long time. They weren't, they appeared to have low screening rates, and then they got on board and got a campaign called Just a Little Prick, which seemed quite effective in terms of getting a lot of men diagnosed with prostate cancer. But we haven't seen any benefit in terms of lower mortality rates yet. And whether we do will be an interesting point. So trends in age standardised mortality in Northern Sydney versus New South Wales. So I think it's the last of my trend charts. And this really shows there's not a great deal of difference, and that was evident from the previous map where North Sydney didn't have a significantly lower rate of mortality than the rest of the state. It tends to be just a little bit lower than the rest of the state, but not statistically significant. It's trending down, so the outcome of prostate cancer now in North Sydney is better than it was 10 years and 20 years ago, but the mortality rate's not shooting down like it is in, for example, the United States. that's the sort of first epidemiologist view about what's going on with prostate cancer. So we tell stories with numbers and statistics, and some of those stories we can't explain, so it hasn't got a happy ending. But that's really where the big picture of prostate cancer is at the moment. The next little set of slides are, I think I'll go through them quickly because it's a little bit not statistical, but it's some techniques behind trying to understand what's going to happen in the future. So most of those stats we're looking in the rear view mirror and trying to work out what's going to happen in the future. And this is a little bit of future gazing to try and work out the prevalence. And the prevalence of a disease is the number of people who are in a community who are living with that disease at the moment, as opposed to the incidence new cases. And so we estimate, based on a couple of the stats that I'll very quickly go through in a minute, that we estimate that at the moment there are about 120,000 men living with prostate cancer in Australia. But that will increase to about 267 in the next sort of 5 to 10 years because of the stats that we're using. They're a little bit old, but we're about to experience a tsunami of prostate cancer based largely on the improved survival, of detection of younger men, and this large group of men who are now getting to an age where prostate cancer becomes very common. That's a little bit of stats about how we did it. We used some Italian modelling. Italian modelling is better than Italian cars, they tell me, so they do work. We used New South Wales data and we plugged it in to get some stats together. Now the next little set of slides are really just a sort of visual graphic about the population changes between 1971, 81, and what you can see here is this sort of big fat blob of males on the left and females on the right that's pushing through. That's 2021, but we're just growing in size and population as that population comes up, and it's this group here that's at risk of being diagnosed with prostate cancer, and that's largely deriving the statistic that we think is going to show that we've got a large group of men being diagnosed with prostate cancer. We did a bit of modelling. We looked at the different curves that we've experienced in the past about incidence, and we didn't like that one because it didn't kick up enough, it didn't take into account. This next one was just using data from 72 to 89 before PSA, and it didn't show a nice effect as well. So we sort of used a combination of two sets of data, and this last one was quite an alarming upward trend that shows that things are really skyrocketing, and it's probably not far from the truth. We also looked at survival, so the length of time that men live after prostate cancer has increased from about 60% 5-year survival before PSA to about 90, 95, 98, depending upon the stage. So men live a long time with prostate cancer, and in some models, men live longer if they've got prostate cancer than if they didn't have prostate cancer, because they're generally a healthier group and have make some lifestyle modifications and changes that their brothers who don't have prostate cancer, who continue to smoke and drink and eat too much and do other things that are going to risk their lives. That's another story. But we put these models together and we came up with a statistic for New South Wales that showed that our model fitted quite well in terms of the estimate of numbers that we thought we'd get if we projected data out from 37 to 38,000. And if we project that to 2014, we got about 84,000 cases in New South Wales. And if we blow that up, because New South Wales is about a third of Australia, that we get to 267,000 new cases of prostate cancer who need various different things, including support groups and cancer nurses and interaction with the health services at different stages, depending upon what type of prostate cancer they've got. Sure.
Sorry, range of diagnosis right now is estimated being between 20 and 22,000 per year. Based on those estimates, what do you expect that to increase to? In terms of the number of new cases that will be diagnosed? To get to 267,000.
The 20,000 a year, even if it plateaus and stays at around about 20 to 25,000, I think is predicted over the next 5 to 7 years because of the population increase. It's the group of men who are being diagnosed at a younger age and then are moving forward and living a long time with prostate cancer.
So it's more a decline in the mortality rate, which is raising that level of...
It's a bit of both, yeah. So the actual numbers, especially as they're based on the figure that I showed where there's a dip in the incidence, The actual numbers might not increase hugely as much as we've seen in the last 20 years, but it's the pool, the prevalent pool will just be filled up every year by new diagnoses, and there's not the drop off at the end that we've seen before with other diseases.
So do you expect the statistical balance in terms of age ranges to remain constant in terms of diagnosis, or do you expect the age to continue to get younger as far as diagnosis is concerned?
I think we probably haven't seen the full decline in younger diagnoses. I think where the increases are still happening in incidence, it's in the younger populations, and I think we're going to continue to see younger men diagnosed, and the average age will probably drop by a year or so, but not vastly, and that will depend a little bit on where everything drops when a bit more evidence and information and data and community attitudes towards screening occurs as well. Because if there are agreements to start screening all men from age 40 or testing all men from age 40, then yes, we'll see a big shift towards younger age groups. But if, as has occurred in the US and the the American Urological Associations, draw a line and say men under age 55 really shouldn't even be offered PSA testing, and if that occurs here, then I think we won't see a huge shift in the age group either. So it depends a little bit about where things go in the next couple of years as well. That's why making prevalence predictions is quite complicated, and unless things continue as they have been, then we could look really silly in terms of the numbers that we're talking about. And that's why we don't really go till much past 2017, so it's not all that hard to predict what's happening just up the road when you don't know what's coming around the bend. Okay, so the next little part of the talk I'm going to talk about is the New South Wales Prostate Cancer Care and Outcomes Study. And this was where am I? Yes, this was a study that I was involved with starting up in 2000, where we looked at the horizon and we realised we didn't really know much about how men were treated, and specifically about what the quality of life of men after treatment was like. So we decided that we needed to follow a cohort of men, so a group of men, and see what was happening. And we wanted to make this a population-wide cohort, so it wouldn't just represent one hospital centre of excellence that has really good outcomes. It would be men from Dubbo and Wagga and Broken Hill and Cessnock and North Sydney and the whole of the state. So we went to the cancer registry and we said we need 2,000 cases of prostate cancer, and we're also going to get men from the general population. They will be our controls, and they will tell us about their quality of life, and then we can balance the two and see what effect prostate cancer has had. Men were aged less than 70, and we had to choose a younger population so that we could follow them for long enough. With scarce resources and finances, we had to choose that particular group also because they were offered the full range of treatment choices. So we got these men. They were diagnosed between October 2000 and October 2002, and we undertook a baseline interview, and then we followed them 1, 2, 3, 5, and for most of them 10 years. And I say for most of them because we didn't do it quite as well as we hoped we would, and we put in a bid to try and get them at 15 years as well. So we haven't finished with this cohort, we hope, but we want to follow them and see what's going on at 15 years. We've got some medical notes and Medicare data, and we've linked them with various sources. And this was funded by the Department of Veterans Affairs initially, and the National Health and Medical Research Council. This is a map that represents where the men came from, so all parts of the state, but of course most men live along the coast, and so this represents largely a nice representation of where men came from with prostate cancer at that time. And this is quite a complicated set of data sources. The richness of doing epidemiology is how much you can link into your original data source, and the inner circle represents the men when we asked them at baseline, and at 1 year we still had 1,908 men and 1,819 at year 2, year 3, year 5. And I say at year 10 we had about 50% of the men. We didn't do this as well as we did with the original surveys, and this was really part of a a survey where we were asking about complementary and alternative medicine use in this group as well. So we do have some data at 10 years, but we'd really like to get the 15-year data. And then outside these, we did all sorts of other data linkages where we're looking at a study that's looking about vitamin D and prostate cancer. And we've got some bloods from 1,183 men. We linked them with PBS. We get 71,000 records and Medicare records. There's sort of a third of a million of records as well. So it's a nice study, and it's produced some nice results that have been very useful moving along. The first thing that we found, I guess, was that most men who were diagnosed with localized prostate cancer had a radical prostatectomy. There's some more recent data from Victoria now, which is backing this up as well. But I think the interesting part here was that when we looked at about 12% of men were getting active surveillance, and there's very much a push or a movement now to encourage more men, specifically with localized, early stage, low risk localized prostate cancer, to pursue active surveillance. We were surveying in the early stages of brachytherapy, so only about 7% of men, or 6 or 7% of men had brachytherapy at this stage. They were both men. It wasn't on Medicare, so they were men who could afford brachytherapy at that stage as well. So I think if we would do this now, we'd see a lower proportion of radical prostatectomies, higher proportion of active surveillance, and brachytherapy. As I mentioned, we did systematic and good quality follow-up to 5 years, and we broke these down by the men down by each of the different treatment groups, and we had very good retention rates from our men in active surveillance. 80% of them were still answering questions at 5 years. 89% of the radical prostatectomies were. 61% of men on androgen deprivation therapy. And that's, of course, represents the group of men who have higher stage grade disease and the worst prognosis. And not all of these men died, but a larger proportion of the men on androgen deprivation therapy have dropped out because they were either sick or unable to complete the questionnaire. Our controls were less motivated than everyone else, and we only had 75% of our controls. Remember, these men who didn't have prostate cancer, so they got a little less invested in prostate cancer research. But not bad nonetheless. And I guess one of the big outcomes that was reported, and we got this into the British Medical Journal, which is a good journal to report findings in, was the proportion of men who had quality of life outcomes at 5, and this is 5 years, at 5 years, by different treatment types. And I suppose the things that draw the eye here are the 12% of men who were self-reported that they were incontinent, and that was being measured by needing to wear one or more pad per day. Men who had radical prostatectomy had the highest rates there. Bowel problems were common in men who had brachytherapy and external beam radiotherapy, but also quite high in active surveillance. And that's because this group of men of active surveillance, this was their initial therapy. And a lot of them, at least 50% of them, then chose a more aggressive form of treatment. Most of them had a radical prostatectomy between baseline and 5 years. The column that obviously always gets the attention is the number of men, or the proportion of men who were impotent at 5 years. And because 60% of the group had radical prostatectomy, this 75% figure often comes up as important. And the men on androgen deprivation therapy, 95% of them were unable to obtain an erection sufficient for intercourse as well, which is not surprising given that it's known that androgen deprivation comes with those particular side effects. We thought this was an excellent starting point for clinicians to start talking to the patients about before they embark on therapy, because we were picking it up a lot that a lot of men were having treatment for prostate cancer and weren't being adequately told about the real risks. And a lot of clinicians will say, it's not my 75% of patients who are impotent at 5 years, it must be all the other clinicians.
No, we've still got a long way to go.
Yeah, we do.
Sorry, was there any explanation for, and were the differences significant as far as brachy therapy was concerned? Like the stats against this chart just look markedly much
The
better
brachytherapy conveys, yeah, Yep, so that's seeds against wires. I mean, wires involves usually triple treatment of external beam, a small dose of external beam radiotherapy, the wires, and some androgen deprivation therapy as well. So these men have got higher stage localized disease as well, and so that's probably why we're seeing poorer outcomes. But the brachytherapy, look at those, actually 43% compared with active surveillance, who had 58%. So it's actually these are early data for brachytherapy, but they show a very sort of positive outcome in terms of potency at 5 years.
Can I ask, what was the percentage of impotency in a control group?
Yep, it started very similarly. Let me see. I think this next one is. It doesn't actually tell you here, but very similar at baseline. About 21% of all men that we surveyed, whether they had prostate cancer or not, at baseline had impotence, or suffered from impotence. At 5 years, it was similar to the brachytherapy group, and it was up to about 42%, I think, of men in the age as they aged, which really backs up where I started today, saying I've been talking from the 45 and up studies, saying that impotence is very common, and it's an inevitable part of aging and occurs. And I guess another way to express that is that we used our control group to measure each of the sexual function issues against sort of background. So you can't really see what proportion here, but we calculated odds, and anything below the line is a worse outcome in terms of sexual function. The diamonds represent the entire period between baseline and 5 years. And where's our brachytherapy? This is our brachytherapy, low dose rate brachytherapy. So there is a decline in the first couple of years when treatment occurs, but it actually comes back close to our control group, because our control group is heading downwards as well, going from about 21% impotence to about 40-something% impotence in that 5 years that we measured. So it's quite a big issue.
Sorry, one of the stats.
Sorry?
One of the statistics that wasn't there was mortality rate. How did the mortality rate compare against each of those groups?
I'll show you a bit about mortality rate. It's here it is. So this is the survival rate. We didn't break it down by treatment groups, because almost all men who had a radical prostatectomy were still alive. So the survival rate was excellent. So this is the survival rate broken down by T stage. You guys are all on with T1A, T1B. Yep. So that's the blue one. That's a very low risk prostate cancer. T1C are generally the ones that you can't detect other than a PSA or a DRE, and the survival rate is 1 represents 100% survival, and at 5 years the survival rate of those two groups is up almost as good as a group of men who didn't have prostate cancer. The T3s not quite as good, and it's the T4s who had really poor survival. Less than 20% of those were still alive at 5 years after diagnosis. So most men, about 88% of men, occupy a position up here. So we did have a proportion of men who were diagnosed with later stage disease, and they have poor outcomes. But by treatment type?
Yeah, I was just wondering, were there any statistics as far as differences in treatment types as far as mortality was concerned?
No, nothing that would allow us to say there's any difference in terms of the treatment.
So there was no statistically significant differences between different treatment types as far as mortality was concerned?
Correct, absolutely no statistical significance.
Wow.
But the only population that had any statistical difference was the men who were on androgen deprivation therapy, and they have that because they got worse disease at diagnosis. 5 years is, this is to 8 to 9 years. 8 to 9 years is probably too short to measure. We actually need to take these figures out further and have a bigger group, and then look at the deaths in that group as well. So it's very few studies, whether they're observational like ours or randomised, have shown a great deal of difference between the treatment types about whether men have radical prostatectomy, external beam radiotherapy, or watch and wait approach if they've got localised disease. Okay, now I'm almost wrapped up, but The last little part of this talk is some research that's underway. In my research unit, we've got about 10 or 11 different projects on prostate cancer. Some of them I've talked to you a little bit about, the prostate cancer outcome study, but this is a new one, and it's a really interesting, exciting one. It's a collaboration with Suzanne Chambers, who some of you might know by reputation. I think she might have been here, launched a book. Excellent researcher. We work very well with her.
She's a good friend of ours.
Yeah, she's fantastic. And she's the principal investigator on this project. I'm a collaborator, and we're running the New South Wales recruitment for this project. It's called Living Well with Prostate Cancer, and it's aimed at identifying whether there are better ways to assist men with advanced prostate cancer by trialling an intervention. And this is sort of the good science end of doing research, and because it's methodologically sound, it involves randomising a group of men, or in this case, to one intervention, and another group of men to something else, and to see whether there are outcome differences at maybe 9 months down into the future. This is the way the project design will work. So men who are eligible, and we're looking at getting about 190 men across the country in Queensland, Victoria, New South Wales and Western Australia. And they will be randomised to receive what's called mindfulness-based cognitive therapy. And I'll talk to you about that in a little bit. It's mindfulness. It's a way of, it's a type of meditation, but it's a way of thinking about things in the present and not cogitating on negative thoughts. I think that's probably the simplest way to talk about it. Versus patient education. So men who are randomised to this side of things will get something else as well, but and everyone will be followed. So mindfulness, as I mentioned, it's an awareness of your current experience and the intention to observe rather than reacting to it. It's used across a number of different health issues and is gathering momentum, not even for particular health issues, but just to make people feel better and have better quality of life in respect to a number of things. So the mindfulness-based cognitive therapy will be an 8-week program, and it's designed to use mindfulness meditation techniques to reduce stress. Not for everyone, obviously, but it's never been well evaluated in a situation like this, and so this is an ideal way to get involved and think about whether it has an effect. So interestingly, it'll be the mindfulness group will be delivered by telephone in groups of about 7 men over 8 weekly sessions. We wanted to do something that we can upscale and roll out so everyone in Australia can get. We talked about filming evenings like tonight so that everyone can get access to it. With something like a telephone-based or delivered intervention, anybody in Australia, so long as they've got a phone, could actually benefit from this. Men will also be asked to complete a workbook and do a bit of practice in their own home as well, and keep on track with the mindfulness. The patient education, the group of men who don't get the mindfulness intervention will also receive a package of resources, so and they'll be followed at the same intervals as well, including advanced prostate cancer books and some excellent material from the Cancer Councils in Queensland as well. So what is involved is a telephone interview to recruit men, and then participation in the weekly mindfulness or education program, depending upon which arm men are randomised into, and then questionnaires over the following months. Some of them will be telephone questionnaires, and some of them will be written questionnaires as well. The next little one is, this isn't for everyone, and we're sort of ending. We're focusing this on the men who are likely to be under more stress than men who've got localized disease. So it's men who've been diagnosed with advanced prostate cancer, and that's proven metastatic or castrate-resistant biochemical progression. Men obviously need to be English-speaking and to be able to complete questionnaires over the phone and have access to a telephone so that they can complete the evaluation or the intervention if they're randomised to that side of things. So we have commenced recruitment nationally, and I think we're about a quarter of the way through. We are recruiting through the SAN, Henry Wu's been excellent in terms of helping us with the recruitment here, and we're recruiting across Westmead, Royal Prince Alfred, Concord, Nepean, and nope, we're about to start at Prince of Wales, and we're looking to have some discussions with Royal North Shore and Liverpool as well. So if you think this is something you'd like to be involved with, then you're eligible. I've got some brochures at the front here, or you can call either Tali in Queensland or myself here and talk to me, or talk to our senior research assistant Sonali, who's helping us do the recruitment and get this moving. So I think that's about what I had to say. I just really want to conclude by reiterating a couple of points and say that so that when you go home you cogitate over this one and think about it a bit more, that we've got the highest incidence of prostate cancer worldwide. We've got a fairly high mortality rate as well, which is unacceptable, and we as researchers want to try and get behind that and turn it around so that we can enjoy the best possible outcomes for prostate cancer, certainly in mortality issues, but also in terms of quality of life. We think the trend in incidence may have plateaued, but the prevalence will increase because of the large pool of men who are moving through who are going to be at risk of prostate cancer, and projecting the prevalence to about 267,000 Australian men who are likely to be survivors. So you are by no means alone, either in this room or nationally, in terms of what you've been through and what you may go through. And I guess really to sum it all up, and what I try and talk about to groups like this and elsewhere, that the survivor issues and quality of life are as important as the incidence issues that we talk about as well. And being involved with a project like the mindfulness-based therapy is something very positive that we can do to try and improve that quality of life for men with prostate cancer or men with advanced prostate cancer. So that's about all I have. Thanks chaps.
Good. Well done, David. Another excellent presentation, so put your hands together if you would like. Thank you. You never disappoint us, so that's great. Now, we have asked some pretty good questions along the way, and we've received the answers. Is there any last questions before we wrap it up? Or are we all over and done? Wait,
You mentioned that you have about 400 employees, some casual. Who pays for all this? Where do you get your money from?
Yep. Cancer Council is almost entirely charity. So we raise our funds through various events like Daffodil Day, and it's coming up, Australia's Biggest Morning Tea, fun runs, Relay for Life, those types of things. The biggest source of income that the Cancer Council has is in bequests. And so that's either in regular bequests, or occasionally we get some big lump donors that make a difference as well. My research group, we have a core component where we are funded partly from within house, but we apply for grants elsewhere. And so for most of the last 10 years, I've been employed on grants, either from the Department of Veterans Affairs, from the National Health and Medical Research Council. We apply for PCFA funding, and we've been lucky enough to get some to do that as well. So there's a mixture of funding streams for our research, but the majority of it comes from Cancer Council, which is community organisation.
What sort of money are you talking about?
Overall, we spend $15 million on research externally as well as internally, so that's what we give out every year. The entire revenue of the Cancer Council, I am not entirely sure, but of course we have shops, it costs money to raise money, and we have the support and advocacy and various other programs as well. I can dig it up and send you an email if you're interested.
It's a big business, isn't it?
It's a business, yeah.
We can add that in the note in the newsletter, David.
Yep. I'll do some homework.
Okay. Any other questions? John?
Just recently we saw something about fish oil and prostate cancer. As an epidemiologist, do you have any comments on that?
Yeah, it was a good study and a very interesting finding. I think the study group, it's not the first time they've found the direction of that effect in terms of even a moderate amount of fish oil in the diet appeared to raise the risk of prostate cancer, aggressive prostate cancer, by about 70%, and all prostate cancers by 40%. Exactly what it means, I think, is unclear, and exactly how the plausible mechanisms between eating fish oil, which is generally seen as a healthy supplement or food, and how it relates to prostate cancer is interesting and unexplained. People have been saying, oh, should I stop taking multivitamins and should I stop eating fish? I think it's probably a little bit early to do that, but one of the sensible comments about that is that just because something is good for you through your normal diet doesn't mean to say that 10 times the amount of it, popping a supplement or a pill, is going to be 10 times better for you and may in fact be detrimental. So wait and see, I think, but I wouldn't go stop eating salmon.
And I think, David, that comment was made by Professor Ian Olver from the Cancer Council of Australia about if something looks good, 10 times more of it doesn't necessarily make it 10 times better. That's basically what he said. Yeah. It gave us an opportunity at PCFA to just remind people that with the medical professionals that we spoke to, there's quite a bit more research to be done on that particular subject. And the other thing that we like to remind people about is a balanced diet with moderation with food and with alcohol, with exercise is really should be the concentration for everyone.
And quality of life as well. If you enjoy eating fish and it makes you feel good, then there's no reason to stop it based on a couple of trials that have seemed to have shown a moderate effect of developing prostate cancer. It certainly didn't indicate that if you've got prostate cancer that you're going to have worse outcomes if you eat fish or take multivitamins.
So again, please help me thank David for a very good presentation.